The second concept is a centralized ophthalmic testing center. And as an example, we're going to use the iPhone. iPhones are wonderful because they combine a display device, an input device, and a computer, all into one handheld portable product. That allows you to do many different things. In fact, if you go to the application store for an iPhone, there are over 40,000 applications that you can run on your phone. These three components are also available in the pair of binoculars. There are display devices in each ocular for each eye. There's an input device, a simple button, a single button on the outside of the instrument, and there's a computer inside the instrument that controls all the operations of the instrument. We feel that a centralized ophthalmic testing center may actually be able to complete many or all of the functions of these devices pictured. We talked about a slit lamp biomicroscope, but we feel that static perimetry, visual fields, keratometry, topography, biometry, pachymetry, autorefraction, visual acuity measurements, many different tests can be boiled down into a single self-administered pair of binoculars. This could potentially save hundreds of thousands of dollars of capital equipment expenses as well as personnel expenses because you need people to operate all those machines. There are certain key features to this kind of device. The first among them is being able to track the gaze of the user. OCT can see the fovea, or certainly the best fixating retina, quite well, and therefore should be able to detect the gaze direction of the subject. So if a person is looking straight ahead, their fovea would appear centrally. People looking to either side, their fovea would shift accordingly. The binocularity of this instrument enables bifoveal analyses that are novel and very useful. Patients should be able to scan themselves, which would allow them to complete almost an entire collection of findings before they even get to the examining room. And it would allow physicians to spend a lot more time evaluating the findings, talking to the patient about potential diagnoses, and implementing treatments instead of spending minutes, precious minutes or longer, collecting findings. Hopefully, the increased efficiency of allowing doctors to perform diagnoses and treatment instead of findings collection should save money, may save time, and overall improve clinical efficiency. So in order to demonstrate all the functions that you see on the left side there, we've put together this simulation screen. In the circles, it shows what the patient would see in the binoculars. The area underneath shows the OCT scans that the instrument would see. There's also a projection image of the eye just to orient the viewer. There's a button on the outside of the instrument that is indicated here, and the instrument also has a microphone to allow voice input with voice recognition software. So, the first example, confrontation visual fields. When you're able to track the fovea, you should be able to tell where the patient is looking. And when I examine a patient in clinic and I want to perform finger counting confrontation fields, I ask them to look at my nose and I hold up fingers. And when the patient looks away from my nose, I ask them to look back at my nose. This instrument does the same thing. It asks the patient to look at the central fixation target, and when they look away, it can tell because the fovea is no longer visible under the fixation target, and it instructs them to look back at the central fixation target. Once you do that, you can present stimuli in the periphery. In this case, we're showing numbers, which the patient would have to verbalize, and the instrument would have to receive through a microphone and voice recognition technology. But as you can probably tell, the same technique can be used for static perimetry, where, again, it's tracking the fixation of the patient, but instead of presenting numbers, it's presenting small stimuli of various brightness and sizes and colors in various locations around this 30 to 35 degree field, and asking the patient to click the button whenever they see the stimulus. This is just like a regular visual field instrument, except that it can be operated by the patient themselves. Kinetic perimetry may also be possible with this instrument. Granted, it won't have the wide angle field of a typical Goldman perimeter. This may only be 30 to 35 degrees. However, it should be able to complete kinetic target perimetry. Again, various sizes, colors, and intensities in the central field, which may be useful for some diagnostic problems. One very exciting thing is the capability of being able to do quantitative pupillometry. Currently, pupillary testing is subjective, it's qualitative, it requires a trained examiner, and in many cases is not completed the right way. One specific example is accommodation. Testing pupils for accommodation may be overlooked by many technicians. Bilateral anterior segment OCT offers an opportunity to perform quantitative pupillometry. In this example, you see what the patient is looking at. There are flash stimuli in each eye, and when there's a flash stimulus in the left eye, you see a normal, direct, and consensual pupillary response because this is simultaneous high-speed binocular iris OCT, so demonstrating the velocity, acceleration, latency, area of the pupil, many different parameters, quantitative parameters that can be acquired at high speeds. In this simulation, I'm simulating an afferent defect on the right side, and flashing the display on the right side allows you to see both an impaired direct and consensual response and to measure that quantitatively. So for patients with afferent defects, they won't be overlooked, and you may actually be able to quantitatively follow afferent defects without having to use neutral density filters or subjective swinging flashlight tests. Another advantage of this instrument is the ability to monitor, measure, and detect strabismus. In the case of an orthophoric patient, when they look in these binoculars at the fixation targets, their foveae should be aligned with the fixation targets simultaneously. But in someone who has strabismus, in this case a right exotropia is being simulated, when the patient looks into the binoculars, the fovea in the right eye will be shifted. And that shift, if you know the axial length of the eye, may actually be measurable to predict the prism diopters required to reduce that. In this case, there's both a horizontal and vertical deviation. And again, the fovea is not visible in the right eye central scan, but you can see in the projection image below, the fovea can be located. And again, knowing the axial length of the eye may allow automated calculations, at least rough estimations, of the prism diopters required to reduce the strabismus, for example, 6 base in, 2 base up. And so when the patient walks into your clinic lane, they may already have the diagnosis or the findings to support the diagnosis for strabismus and a measurement that you could begin testing the prism measurements to reduce their strabismus. There will be cases where the strabismus is wide enough angle that the instrument can't see the fovea or even the retina, and in those cases you simply have a black image. But for the purposes of screening, we hope that this would be an immediate referral because this could be a tumor or other media opacity as well as strabismus. For the purposes of clinical measurements, this wouldn't be measurable, and you'd have to use standard techniques for measuring this deviation. Forias may also be quantifiable with this instrument. By alternating the fixation targets, you can simulate a cross-cover test which will break fusion and thus elicit forias. Again, quantitative forias may be a new way of examining forias in patients with strabismus. Another exciting thing that this can do is quantitative extraocular motility, both versions and inductions. When a patient looks at these fixation targets, the fixation targets can be moved around the field of view, and the patient can be asked to follow them. If the patient follows the fixation target, as you can see, the fovea should remain located on the fixation target all the way around. In this example, I'm simulating a right lateral rectus palsy where the fovea can't make it out all the way to the right side. And that can be quantified by measuring the foveal location. Here's a normal quantitative plot. These are octagons. The green line shows the normative data for what you would expect a normal patient to do, and the red line is the measured movement for this particular patient. Now, I showed the simulated lateral rectus palsy, which is actually the bottom example. And what you can see with those measurements, the red line shows the deviation from the norm, and you can actually estimate based on how many bars it crosses that this person only had 45% activity. Instead of using, again, -1, -2, -3, you now have quantitative numbers to measure how far out that person got compared to where they should have gotten. And in the example in the middle, here's a simulated A-pattern esotropia. You can see the muscles that are overactive, underactive, and in planning your surgery, you might actually be able to know more accurately which muscles to recess and resect. Also, postoperatively, you should be able to follow people more quantitatively to refine your tables, refine your techniques, so hopefully you'd end up with better results in subsequent surgeries.